the other ones. Yeah, I mean, there's a fine line between dependence and addiction. And dependence is just having to use the drug to get to sleep for a sedative. Addiction is using it despite negative consequences, at least in the case of this class. That's how we define it. And so there would have to be something in addition to just the withdrawal syndrome from the drug to actually consider it addiction. Because almost everybody that uses a barbiturate or benzodiazepine on a regular basis becomes dependent. Not all of them become addicted.
If you're using it as prescribed, is it still addicting?
Well, we'll get to that, and I have a slide specifically on that. But what I would say is that it comes down to how do you define addiction and what is addiction? Where do you draw the line? What's too much? What are the negative consequences that you consider to be sufficient to define addiction? So it's still something that's hotly debated. And in fact, one of the things that Purdue did in marketing OxyContin was to try to draw a very distinct line between dependence and addiction, because anybody who uses an opioid for a long term, more than 6 months, is going to be dependent. They're going to have withdrawal when you stop using it. But does that mean they're addicted? And Purdue said, no, that doesn't mean they're addicted. It just means they're physically dependent or physiologically dependent. And we'd like to very clearly state that there aren't any necessary or there are no negative consequences other than the withdrawal syndrome, and therefore it can't be addiction. Well, so anyway, when it comes to benzodiazepines, they are formed from this benzene ring and a diazepine ring that are joined. There's also usually another benzene ring attached. And this is the chemical structure of a number of them. You've got Xanax, Klonopin, Ativan, Valium, and then a couple that are not FDA approved, but are used in other countries, and then some that are designer drugs that people use to try and avoid getting in trouble. But one thing I did want to draw to people's attention to is how easy it is to distinguish a Xanax from any other tablet, or a Klonopin with the K on it, Valium with a big V cut out of it, or Ativan actually made in the shape of an A. How many other type of drugs do you know where they've gone to that length to make sure that anyone, not a pharmacist, anyone can distinguish their brand? Fun. So benzodiazepines remain the first-line treatment for seizures and status epilepticus. They're also a short-term treatment for anxiety and insomnia. They are a first-line treatment for alcohol withdrawal reactions, but I would draw your attention to this is supposed to be during detox, not when somebody is saying, oh, I just feel bad, because they can get the same basic effect of taking a drink from taking a benzo. So if they tell you they're clean and sober, but they're taking benzos, that's probably not true. The other thing is that they're frequently used as a sedative to induce relaxation prior to surgery. The clinical uses are many, but I would say the vast majority of them are meant to be short-term. I'm not expecting you to know this table. I'm just showing it to you because there are a wide number of uses for benzos. They're not good or bad. They can be used for either one. And I couldn't help but include this little ad: sweet, refreshing Valium, when denial is the best alternative. And Valium used to be called Mommy's Little Helper. And here we have the Valium gone wrong with heroin, Kurt Cobain. So benzodiazepine prescribing rates have decreased a little bit between 2013 and 2017, but you can see that the rates increase with age. And in an ideal world, you would see that go like this, because by the time you're 65, you should not be taking a benzo. But obviously, that is not what happens. And this is the difference between genders. You have males in yellow, the purple is the females, and you can see it's roughly 10%, 9 to 10% of women, and about 5 or 6% of men that are using a benzo. And that represents about 3 million patients in the United States. Yep. Well, that's part of it. I think another part of it is that women are more likely to make an appointment to go see their doctor and do something about the anxiety. And another part of it is that women tend to be more in touch with their feelings than men. Men tend to stuff their feelings and then explode when the feelings get to be too much, often with violent consequences. And that's what anger management's all about. Just for men. Women never get angry, don't worry. And then benzodiazepine use rate, once again, this is with age. And once again, by the time you're getting into your 50s, you should be considering stopping maybe by here. but it doesn't happen. It just keeps going. So these are the America's most prescribed psychiatric drugs. Xanax is number 1, then an antidepressant, then Ativan, then 3 antidepressants, an antipsychotic, another antidepressant, and then Valium. So you've got the bar, the big A, and then the V tablet. And this is estimated prescription rates of potentially inappropriate barbiturates in people that are 65 years and older. And not too surprising, this area, the ones that usually have trouble with poverty, the ones that also have trouble with diabetes, the ones that have trouble with heart disease are also the ones that tend to use the barbiturates, I guess because it's something that, you know, their parents used and they don't know any better. I don't know, but that's where it's preferentially still used. And then this is benzodiazepine prescribing. Not a whole lot different. Still, this part of the country is where most of the anti-anxiety medication is consumed. You'll also note that Kentucky and Tennessee were those states that are dry, along with West Virginia. I'm sorry, it's kind of funny to me that they would make a dry state but then allow benzodiazepines. But anyway, so very high usage in those areas. Did you see that? Oh my God, most people are using benzodiazepines to relax and relieve tension. Even though these people are supposedly misusing the benzo, they didn't get it by prescription, still the majority of people are using it for the same reason that people get the prescription. So, and then all right, you bet, to help with sleep and emotions, another big chunk of the supposed misuse. So here's the frequency of diversion by drug. So this big bar here is Xanax, the bar, by far the most misused of the benzodiazepines. Klonopin is the big pill with the K cut out of it. Diazepam is the pill with the V cut out of it. And lorazepam is the pill that's actually shaped like an A. So the 4 most diverted benzodiazepines are also the ones that are most easily recognized on the street as being brand name, fantastic benzodiazepine. You want to pay mucho dinero for this. Also, of course, you know, now that people are making counterfeits, they try to imitate the shape of the pill and often put fentanyl in it because that's a lot cheaper than a benzo. So let's talk a little bit about the epidemiology of benzodiazepines and barbiturates. First of all, what is a tranquilizer and what's a sedative? So these are 2 groups of medications, and specifically it's the National Survey on Drug Use and Health from SAMHSA that uses these 2 categories. What I would like you to remember from this is that tranquilizers are generally the benzodiazepines. So that's that group. Sedatives are generally the barbiturates. In addition to the barbiturates, sedatives include all of these sleeping medicines as well. And tranquilizers include muscle relaxants. Most of the other stuff in this group is not widely abused. Generally, the things that are most abused are Xanax, Klonopin, Valium, and then Soma, and this meprobamate when it was being prescribed, which actually, these are one and the same. This meprobamate is a precursor molecule that is metabolized in your body to Soma. So they're basically the same thing. So when we speak about tranquilizers, think benzodiazepines first and foremost. When we speak about sedatives, think barbiturates or sleep aids. And looking at specifically what the difference is between sedatives and tranquilizers, sedatives are molecules that act as depressants and have the ability to act as analgesics, which means they kill pain, physical pain, or for that matter, psychological pain. Tranquilizers, on the other hand, just act as depressants. So benzodiazepines are primarily just depressants. Barbiturates are both depressants and analgesics. So after taking a barbiturate, are you able to move? Generally not. After taking a benzodiazepine, are you able to move? Well, you have some ability to move, but you're often impaired if you've taken a large dose. And then, are you aware of your surroundings? Usually with a barbiturate, you're not. And with a benzodiazepine, you have moderate to low awareness of your surroundings. All right, and then what I was trying to give people an idea of here is how many people actually use any tranquilizer. That's in blue here. It's about 15% of the population. And this is as of 2015. That's the last time that SAMHSA and the National Survey on Drug Use and Health published detailed information about prescription drug misuse. And because barbiturates and benzodiazepines are both prescription medications, I have to refer to that for the detailed information. But anyway, when it comes to benzodiazepines, about 11% of the population use benzodiazepines, and about 2% of the population misuse benzodiazepines. Now, in yellow here is the relative abusability of those compounds. It's just a relative thing. There's no actual meaning to the number. It just shows that of the things out there that people abuse, Soma is one of the #1 things that people abuse, and Xanax is a close second.
No,
Not surprisingly, given that
no, my mic is unmuted. Huh? No.
Given that meprobamate is a precursor molecule of Soma, it's not surprising that it is also highly abused. All right, so keep this in mind when we look at this next slide. You can see that any person using a sedative, the amount of actual abuse or misuse of sedatives is 0.5%. So it's about a quarter of the people that actually misuse tranquilizers, the number of people that actually misuse a sedative. So once again, here's the barbiturates in the sedatives, and these are the sleep aids. So when it comes to relative abusability, for some reason, this triazolam, which is a benzodiazepine sleep aid down here, triazolam, is one of the most abused, but its abuse index is about a 6 compared to Soma, which is almost a 10. So not only are there far more people, like 4 times as many people that use tranquilizers or misuse tranquilizers, there are also far more people that abuse compared to the number of people that are using Soma, that abuse it, and the same with Xanax. There's a lot more people abusing Xanax or misusing Xanax compared to the number of people using it than any of the sedatives. So once again, we're going to refer to the National Survey on Drug Use and Health for 2021 for some of the information. And the other thing that we're going to be using is this 2015 further, I guess, data review. But anyway, they looked at prescription drug use and misuse in the US in a lot more detail in this report from 2015. So we get a lot of the detailed information from there. Otherwise, I'd have about 4 slides to show you, which I know would be a tragedy, but you also wouldn't learn a whole lot. All right, so looking at past year initiates, you've got 881,000 people that started using a tranquilizer in 2021. And then for sedatives, it's about a quarter of that at 188,000. So in total, you have about 1 million. But the problem is that a number of these people that started using sedatives also started using tranquilizers and the other way around. Then this is looking at the long-term trend from 1965. So this is all the data that's available in terms of the initiation of tranquilizers or sedatives. And back here from the mid-60s through the mid-80s, there wasn't a whole lot of difference between the number of people that were starting to use tranquilizers versus sedatives. But by the early 90s, you have a marked difference. And then through the mid-90s to the early 2000s, you have the number of people using tranquilizers, which are benzodiazepines, increasing rapidly. And the number of people using barbiturates or sleep aids doesn't change much. And then through the mid-2000s, through about the beginning of the pandemic, 2019, you have a slow increase in the number of people using benzodiazepines. And then in 2019, 2020, and 2021, the number of people dropped using tranquilizers or benzodiazepines. And also the number of people here using sleep aids or barbiturates seem to go down, at least in the most recent data point for 2021. And then again, this is from 2015. But this is looking at the age distribution of people who started using one of these prescription drugs. And we're specifically interested in the tranquilizers and the sedatives. And you can see that it's later in life that people start using tranquilizers or sedatives, either one. The vast majority of people that are starting to use are 26 and older. And this gives the average age at which people started to misuse a tranquilizer or a sedative. And 26 years for tranquilizers, which are benzos, and almost 30, 28 for people that are misusing sedatives, which are either sleep aids or barbiturates. And looking at past month substance use, you've got tranquilizers or sedatives at 1.4 million very faithful users of one or the other or both. And when it comes to the number of people, it's kind of funny that they put this in illicit drug use, but I guess you can get a tranquilizer or a sedative from other than a doctor. But anyway, so it's ranked amongst the people using illegal drugs. And this is looking at past year. And there were about 5 million people that used or misused rather a tranquilizer or a sedative in the last year. And that's part of this 20% of people that have used or misused rather a illegal drug. Then when you look at prescription psychotherapeutics, have not used one, about 55% of the population, have used one in the last year, about 44% of the population. So of those, there's a fairly large number of people that have used a tranquilizer or a sedative. And this is not misusing, this is just who's using them. In people that are 12 and older, you have about 40 million people using a tranquilizer and 18 million using a sedative. And then we go to misusers. So in the last year, roughly 7% of the population misused a psychotherapeutic. Most of them were misusing a pain reliever, but we do have 6.1 million and 1.5 million misusing a tranquilizer or a sedative. So then I was looking at as much information as I could find. The data only goes back to 1985. Much of the problem with doing epidemiology on drug use here in the United States is the further back you go, the less information you have. And it's not just because people were keeping records on paper and not in a computer, but it's also because there wasn't as much interest in knowing who was doing what back then. It was only with the advent of computers and statistics back in the 60s that there became any interest in the public health in terms of what drugs were being used by whom and in what amount. And that's what, at least in part, brought about the Controlled Substances Act in 1970, was the fact that people started to recognize that looking at the epidemiology of this could both help to alert the authorities to the fact that there might be a problem before it became evident. Because prior to the Controlled Substances Act, the vast majority of prosecutions were because of some story in the popular press about misuse or mismanagement of patients. So it had to become an issue in the news, basically, before the DEA or FDA or any of these other regulatory bodies would have anything to do with it. But with the advent of modern statistics and computers, they started getting better and better information. And it wasn't until very recently, like within the last 5 years, that more than 90% of drug-related deaths actually specified which substance was involved, which to me is baffling why it would take that long. But the vast majority of the time, I guess the medical examiner or the coroner doesn't have a lot of time to try and figure out why the person died or which drug was involved, or drugs for that matter, and they just put it down as drug-related and on to the next one. But anyway, so this is looking at, have you ever used a tranquilizer? And they stopped collecting that data in about 2014 because of measurement issues, they said. And have you used a tranquilizer in the last year or the last month? And so this is a trend from 1985, which is the most, the furthest back that data goes. So obviously tranquilizers, or most likely these were sleep aids back there in the mid 80s, were misused. And then the number of people misusing dropped considerably during the late 90s, and then rebounded actually really fast around 98 to 2002 for some reason, right in here. And the number of people per year went up a bit during that period, and the number of people per month increased as well. The numbers of lifetime users through the end of measurement were increasing for tranquilizers. And in this period, I'm pretty sure that the majority of these people are misusing a benzodiazepine. The number was pretty steady in terms of the number of annual users at about 2% of the population, that is, of people 12 and older. Recently, in the pandemic, the number has gone down. So you got 2019, 2020, and 2021. And the number of monthly users has gone down as well. So we'll see whether it's just a blip because of the pandemic or if it actually holds. Hopefully it holds. Because if you add sedatives, then those are in green here, the tranquilizers are in red, then the lifetime number of users decreased since the mid-80s. And it rebounded here in this same period, and then it was on a slow decline. Most likely a generational thing because barbiturate users are dying off and physicians aren't prescribing barbiturates very much. The number of annual users of sedatives, number of monthly users of sedatives are both lower than the monthly users of tranquilizers. So a small number, less than 1% of the population, on the order of 0.1% by 2021. And then finally, they did add a category specifically for benzodiazepines, but they only added that as of 2015. So of the people that are using, they also added this category, either a tranquilizer or a sedative. Of the people that are using a tranquilizer or a sedative, the vast majority of them here in blue are using a benzo. So that means the vast majority of them are using a tranquilizer. And that's this number in red. Tranquilizers, here's the number of people using a benzodiazepine. And then down here is the annual number of people using monthly, using either a tranquilizer or a sedative. So these are the ors, either one. And you can see that they are closely followed by the annual and monthly number of tranquilizer misusers. So almost all of the people that are misusing one or the other group are misusing a tranquilizer. And almost all of those people are misusing a benzo. So that's the take home from this information anyway. Although the number of people misusing it is on the decline, the vast majority of people are misusing a benzodiazepine. And it represents currently about 1.5% of the population. So the most recent graph in terms of age trends for either misusing a tranquilizer or a sedative shows that the majority of people in the past year that misused one were in the age group of 18 to 25. And that was about 4%. So then this is looking at the age distribution of past year prescription tranquilizer or sedative misuse compared to stimulant misuse or pain reliever misuse. So this is the one that we're concerned about today. And this is recent data. So as of 2021, still the majority of people that are misusing one in the past year is in the 18 to 25 group. And I guess overall, it doesn't matter whether it's 12 or older or 26 or older, the rate is still about 1.7% of the population. So then this is older data from 2015, looking at the age distribution of any psychotherapeutic pain relievers, tranquilizers, or sedatives. So it doesn't matter whether it's tranquilizers or sedatives, it's still mostly in the 18 to 25 group. And then looking at gender differences between guys and girls. For tranquilizers and for sedatives, the rates are similar, but there's slightly more guys using benzos and slightly more women using sleep aids. And then this is misuse versus appropriate use of a psychotherapeutic in general in the population. So you have a total in 2015 of about 120 million people that used some type of psychotherapeutic in the last year. Of that, 16% of them misused it. And then we're concerned primarily in this section with the people that were using tranquilizers or sedatives. And you have a misuse rate for tranquilizers of 15%. For sedatives, it's 8%. So roughly on a percentage basis of people that use a tranquilizer, they're about twice as likely to be misusing it as a sedative. And the number of people that are actually using one is roughly twice the number. So there's twice as many people using tranquilizers And of those people, they're roughly twice as likely to misuse one as a sedative. So here's a fun graph. And the point of this graph is simply that people rarely misuse a tranquilizer in red or a sedative here in green in isolation. In fact, the isolated tranquilizer or sedative user almost doesn't exist. Because here's the number of people that use alcohol that also use a psychotherapeutic. It's almost 50%. Of that, about 10% of them are misusing a psychotherapeutic. About 15% of people that use alcohol are using a tranquilizer as well. And about 8% are using a sedative. And then this is the number of people that are actually misusing one. So you'll note, as you go from alcohol to cigarettes, then marijuana, inhalants, hallucinogens, and then what are considered the hard drugs, you have a constant theme here that people are more and more likely to use and abuse tranquilizers and sedatives as you go along this, I guess, spectrum of a drug that almost everybody uses to a drug that almost nobody uses, but the very most devoted, quotes, junkies. So the vast majority of heroin users, about 93%, use some type of psychotherapeutic, and almost 80% of that 90%, or 80% of these users rather, are misusing a psychotherapeutic as well. So once you get to heroin users, almost all of them, 9 out of 10 are using a psychotherapeutic, and 8 out of 10 are misusing one. All right, and then when it comes to substance use disorder, the reason I left this in here is because you won't find tranquilizers or sedatives in isolation as a disorder. Generally speaking, it's some other drug that people are primarily receiving their treatment for. And in addition to having this problem, they may also have a problem using a benzodiazepine or a barbiturate or a sleep aid. And that's what this graph represents, is that almost everybody who uses one of these drugs also uses a psychotherapeutic. So the majority of people get diagnosed with one of these drug disorders and not a psychotherapeutic, even though they're using them. So this is looking at substance use disorders for the psychotherapeutics and just showing you why it's not on that other graph. The number of people that are diagnosed is roughly 1% of the population. For tranquilizers, it's roughly 1/3%, and for sedatives, it's roughly 0.1%. So compared to these numbers are diminishingly small. And then of the people that have a substance use disorder for one of these prescription psychotherapeutics, in what age group are they? For tranquilizers and for sedatives, the majority are in this 26 and older age group, both. And then this is looking at prescription psychotherapeutics for which the most recent treatment was received. And pain relievers actually represents a fairly large number of people who receive treatment, but tranquilizers and sedatives are a small percent, 8% and 3%. And then this is looking at the difference between people with depression and without depression in the youth age group of 12 to 17. And as you might expect, people with depression are much more likely to abuse or misuse a psychotherapeutic, twice as likely, or actually more than twice as likely for pain relievers, more than twice as likely for tranquilizers, and almost, 2.5 times as likely for sedatives. So both sedatives and tranquilizers are about 2.5 times more likely to be misused by people with depression, youth with depression. And this is looking at adults 18 and up with depression. Same idea, tranquilizers and sedatives, except this is 4 times as likely, and so is this. So, oops, sorry. Instead of being 2 times as likely, it's 4 times as likely for adults with depression. And then this is looking at the rates versus mental illness. None, acute mental illness, or severe mental illness. And once again, not too surprisingly, tranquilizers and sedatives are much more abused or misused by people with either acute or severe mental illness. This one is on the order of, 6 to 7 times. And that one is as well for people with severe mental illness. And given that people that are depressed and have mental illness preferentially misuse tranquilizers, sedatives, pain relievers, and stimulants, it's not surprising that people who have suicidal ideation or thoughts of suicide are much more likely to misuse. This is 5 times more likely. And so is that. Only it's more like 4, but you get the idea. So people, I'm not saying that suicide causes people to use tranquilizers and sedatives. I'm saying that the same people who have depression and acute mental illness or serious mental illness also often have thoughts of suicide. So it's not surprising that the rates of misuse are much higher amongst people with those issues. So then this is just kind of summarizing the whole thing. In this young person age group, try that again. You have a relatively low level of misuse of about 5% and a level of use of about 28%. And the majority of that is amongst people with depression. You can see that when you don't have depression and you're in this age group, the level of misuse is a bit lower. For people with depression, the level of misuse and use are higher. And then for adults in the age group of 18 and up, the level of use and misuse is higher. And then for people with acute mental illness, but not serious mental illness, acute mental illness of any type, serious mental illness, depression, or thoughts of suicide, you can see that rates of use and misuse are much higher for all categories, whether it's a psychotherapeutic in general, a tranquilizer, or a sedative. And then looking at monitoring the future, they have tranquilizers, which are generally the benzodiazepines. The rate of use back to 1975, all the way up to 2022 for seniors, and then for 8th and 10th graders from 91 on. And that same trend, higher back here in the mid-70s through the early 90s, trending down, and a trend back up through the early 2000s. And then from there, it's been trending down. And whoops, during the pandemic, it's gone sharply down. Small rebound recently, but it's on the order of 2%. For sedatives / barbiturates, same trend, much higher in the mid-70s, trending down, up, and back down. And right now it's on the order of 2.5%, 3%. So the other thing to keep in mind when it comes to the epidemiology of sedatives, tranquilizers, whether you're talking specifically benzodiazepines and barbiturates, is that people with a substance use disorder in the United States have a rate of benzodiazepine misuse that's between 3.5 and 24 times higher than the general population. So if you have any type of substance use disorder, your chances of using a benzo are much higher. And the misuse of other substances is most consistent and robustly correlated with benzodiazepine misuse. In fact, it is unclear how frequently benzodiazepine misuse occurs in isolation. Well, they estimated it to be on the order of 0.5% of the population. Rather, it's usually part of a polysubstance use pattern, which is very common these days. In fact, when they were doing this assessment in 2018, 63% of opioid deaths were not opioids alone. They were opioids in association with cocaine, 1/3 of the time, and benzodiazepines, 1/3 of the time. And then also to refer back to what Dr. Herzberg's point was, at least one of his points, and that was the massive amount of use of sedatives in the early to mid 1900s. The actual amount of sedative use up until it was scheduled in 1970 was increasing at a very rapid rate. So was the amount of people that were dying of sedative overdoses or barbiturate overdoses, and that's something that is addressed in the lecture. There's actually better data from some countries in Europe, including the United Kingdom, regarding that. But the number of people that were dying per day or per 100,000 people in the population was actually greater than the number of people until probably recently that were dying of opioids. So there was a definite epidemic of barbiturate overdose that is equivalent to the opioid overdose that we're experiencing right now back in the 60s and late 50s, early 70s. So this is again making that point that as of 2020, the number of people that were using an opioid and a benzo was on the order of 11,000 deaths. And at that time, there were only about 70,000 overall opioid-related overdoses. So a little over 1 in 7 of those opioid overdoses were involved with benzo as of 2020. So the pharmacokinetics, some people think, it's a lot of fun. However, this Hemingway actress was the granddaughter of Ernest Hemingway, died of a fatal suicide with clonazepam and phenobarbital. So both a benzo and a barbiturate. Well, no, she used too much of them, possibly a handful instead of the normal 1 or 2, and died. And so they considered that a suicide. And thus the X's on the eyes of the smiley face. Yeah, I mean, certainly in withdrawal, you can get hallucinations. That's when you start. Well, when you are withdrawing from benzodiazepines or barbiturates, you can get psychosis. You can end up in a mental hospital for a while. So these are the ones, this is looking at lipophilicity versus hydrophilicity. So this is water down here, the H2O. And this is oil up here. And the reason this is important is, like for most drugs, the ones that are more lipophilic cross the blood-brain barrier much more rapidly. They can also be absorbed through the skin. And they often have a 2-compartment metabolism model, as opposed to the ones that are easily dissolved in water that have more of a 1-compartment metabolism. And we'll get into that. But the half-life is also listed here. So you can see that oil or lipophilicity, hydrophilicity don't necessarily directly correlate with how long the drug lasts in your system, or it has an effect in your system. And benzodiazepines and barbiturates can be administered by almost any route, but of course the most common is orally. When it comes to intravenous, there's actually usually only one that's effective, and that's diazepam. And then for intramuscular, there's only a couple that are actually effective, and midazolam and lorazepam. A number of the others, you can give the injection intramuscularly, but you don't know how long it's going to last, because it depends on exactly where the shot landed and on the individual you gave the shot to. So as a physician, that's not a good idea. And sublingual administration also avoids the first pass effect and results in more rapid absorption than oral administration, swallowing it. Oh, well, sublingual, yes, you could chew it up as long as you don't swallow it. I wouldn't recommend it because this stuff's horribly bitter. But if you can tolerate that, you could absorb it more quickly. But there are actually some that are made as a preparation to dissolve on the tongue. A little wafer or a little, it looks kind of like one of those breath. Yeah, like that. It just dissolves on your tongue. Some of them look like a little strip, like those breath strips or whatever, but instead it has a benzodiazepine in it. So this is looking at triazolam and its pharmacokinetics for intravenous, oral, and sublingual administration. The IV, you can see that you get a fairly high concentration and it's rapidly falling. So this is what I would consider the distribution phase. This is where it's binding to, or primarily binding to, proteins. This almost straight line is where your elimination is being dominated by metabolism of the extra triazolam in the bloodstream. And this final phase, which is almost a straight line but of a different slope, is where you're eliminating the protein-bound triazolam. So you have a binding phase, then, distribution, binding, metabolism, and then release and metabolism for the 4th period. So the fraction absorbed compared to the IV for sublingual or oral is about 20%, and that's why these curves are much lower. And bioavailability is about 44% and about 53% for sublingual. So first pass accounts for this difference between these two, because the sublingual here is in green or blue and the oral administration is in yellow, The IV administration is the one here in red or brown. So another accidental overdose with several benzodiazepines and some coke. Don Simpson, producer of Top Gun and Flashdance. He was doctor shopping and he got almost 15,000 pills from 15 different doctors. Only one of those physicians lost their license. I don't know. To me, that's always a tough call.
So the doctors pretty much become addicted to the market and get whatever they had for. Isn't that, we're not gonna joke. I mean, it's something like,
See, this is prior to that system where you could tell where somebody was getting medication before coming to see you. So most of these doctors had no idea that this guy was going to 15 or 14 other doctors to get medicine. And often these people got smart about filling, so they would go to different pharmacies. So without a system to be able to tell where this particular patient has gone before, the pharmacist wouldn't even know. Because as long as you go to 15 different pharmacies to fill 15 different doctors' prescriptions, without some kind of database that's recording all of that, nobody will be any the wiser except for you. You'll have 15 bottles instead of one. And I would say there's very few doctors. I'm not going to say there's none because there's always exceptions, but very few doctors that actually ignore the addiction and would write just willy-nilly for whatever you want, however much you want. I think anybody in that situation as a physician is somebody who's feels disgruntled by the system to the point where they just don't care anymore. And they're so damn tired of trying to pay their bills by playing by the rules. They're ready to become a drug dealer with a prescription pad. But those are by far the exception. I would say the vast majority of doctors that get involved in this kind of thing have their heart in the right place. They're trying to do the right thing. And the patient is constantly coming to them and complaining, I don't have enough. I keep running out before this prescription, before I'm supposed to be able to renew, and I'm trying all of these other things that you suggested. They're just not working. So I'm unable to sleep because I don't have enough, whatever, Valium, Xanax, whatever it is. So can you please write me some more? And so then as a physician, you have to turn like practically either law enforcement or attorney in your head and be like, well, I think this guy's lying. Where doctors, I can speak for myself anyway, that's not a call you want to have to make as a physician, whether somebody's lying, because your training anyway is to take people at their word. That's part of being empathetic. So when you have to suddenly start taking the law enforcement side of things and being suddenly concerned about, whether somebody's actually telling you the truth, then the system's already broken down. And to say that, doctors are fueling this prescribing frenzy for opiates or opioids, I think would be also incorrect, because there was a tremendous amount of pressure put on the healthcare system to respond to untreated pain, which is still a problem. But you still have the problem that people will lie to the doctor and say that they're in intractable pain when they're not. So then it's up to the physician somehow to figure out, are you telling the truth or not, when there is no painometer? I can't do an objective test on you, no matter how many tests I do, to find out if you're in legitimate pain. Once again, it comes down to, to a certain extent, what is legitimate? Are you just hypersensitive to what everybody else can actually tolerate just fine, and therefore you need pain treatment? Or are you actually, have a nerve that's been trapped, or, some other traumatic problem? Or is it all in your head, quotes? Well, the problem is, as we've already covered, psychosocial pain activates the same part of your brain. So if we do the functional MRI, which people would say is the gold standard of being able to determine if you're in pain, it wouldn't matter whether you're actually in physical pain or psychosocial pain, the same part of your brain would light up. And I'd still have to write you the prescription, and you'd still be lying because the pain isn't actually physical. No, it feels physical. So you're not lying. God damn. When are we going to come to the truth here? What's wrong with a little bit of pain? Well, my guess would be that it has to do with the problem of more. That people are so focused on that pleasure that any pain that's getting in the way of getting that pleasure suddenly becomes intolerable. And if people were more focused on how are we going to get by with what we have and make sure that everybody else around us is part of the community and has enough too, that all of a sudden the focus would be no longer on me and my pain, and it would be on how's the community doing.
I think if you learn to tolerate some sort of pain, it kind of makes you, it opens the doors to, I don't know, being more empathetic and more sensitive to other people. And
it can, but I think once again, it's one of those things where your experience doesn't necessarily lead down one path. You have some people that experience chronic pain and they become complete blankety blanks.
well, it depends on you, like your perception and how your effects. Yeah, and how you feel.
Yeah, are you entitled to pain? Are you entitled to a pain-free life? And then all of a sudden you get pain. But I would say that pain can be useful. in that it can help to make people more aware of the people around them and how much other people might actually need help. And that pain doesn't have to be physical. It could be, you know, food insecurity, housing insecurity, any number of the pains that come with poverty. And, you know, if you've ever experienced that, I think you become a lot more empathetic to people that fall into that category, and you become a lot less blind to their problems. And in that way, I think that pain can be very useful if you were then to become a person who is in power. If you remember it and you actually value trying to help other people not experience that pain, or at least not experience it as much, I think that could be great. But if you remember that pain and you absolutely deplore it, and you think everybody else who's experiencing it is just a whiner, and you want to ignore it, you're going to get drunk or high or something, and you're going to, you know, if you have the means, you're going to obliterate the memory of that pain with whatever you can get your hands on. And in that way, that pain could be a horrible thing, you know. Jails, institutions, and death. Anybody? But when it comes to the absorption of benzodiazepines, they're readily absorbed through the lining of the mouth, the stomach, or the intestines. The more lipophilic they are, the more rapidly they absorb. The more fat, the more rapidly their onset. And with that comes, if you're going to experience euphoria, that's what usually drives it. That's also part of what makes tobacco so addicting, and anything that you inject IV so addicting, because it hits you really fast and really hard. And when it does that, that change in neurotransmitter levels, specifically dopamine, is what you notice. And if that's also associated with an opioid level change or endogenous opioid level change, you're going to say, I like it. Not only did I notice it with dopamine and I want it, but I also like it. And therefore, you're going to be hooked. But for all of them, the maximum plasma concentration occurs in about an hour. Yeah. When it comes to distribution, the ones that are lipid soluble have a faster onset because they can cross the blood-brain barrier more rapidly. They usually have a shorter duration overall. They are partially sequestered in body fat and serum protein, and that leads to this two-phase excretion curve that we were saying, you know, the one slope and then the other slope. All benzodiazepines are widely distributed, and most of them are highly protein bound. And by highly, up to 95% of it is bound to a protein and not free in the blood. And the difference is the ones that are lipophilic end up in this phase binding to a protein. And thus it looks like elimination, but actually it's being bound. And then in this part, they're being metabolized and also removed from the protein. So the elimination is slower. In the hydrophilic one, it doesn't bind to the protein, so the concentration is a little bit higher, but you also have this single phase of elimination. So you don't have a reservoir of the drug bound to protein. That's what this is talking about. The hydrophilic drug doesn't bind to albumin, which is the predominant protein in your serum. It does have 8 oil-loving binding pockets where a lipophilic drug can bind, and other lipophilic substances in your blood, like hormones and cholesterol, also can bind to these proteins, and that's how they get transported around, because oil droplets don't usually mix with blood. But when you can get the lipophilic substance bound to the protein, then it can travel through the bloodstream, and eventually it will come off of here and diffuse. So the distribution for very large drug molecules is usually confined to circulation because they can't get through the pores in the capillary. For very polar drugs, they can make it through the pores, but they can't make it through the cell membranes of other cells to actually have much effect. The lipophilic drugs are the ones that are ending up in fat cells as well as in your circulation. And drugs that are hydrophilic end up with a more even distribution, although being perfectly uniform is very uncommon, because as we mentioned already, you know, you have to either be a weak base or a weak acid to get through the stomach wall, and that's how most 95% of drugs are absorbed anyway. So because these drugs can easily cross the blood-brain barrier, they can also easily cross the maternal fetal barriers, like the maternal circulation, placental circulation barrier. And the more lipid soluble they are, the more effect they have on the central nervous system of the mother and of the fetus. And they can cause fetal depression as well as respiratory depression. And there is some evidence to believe that benzodiazepines can cause birth defects. And they also can easily enter mother's milk and cause suppression or depression of the neonate. And benzodiazepines during the third trimester have been shown to increase cleft lip and palate. The fork right here, so that the lip is actually separated. Fetuses can easily become physically dependent on the benzodiazepines and undergo withdrawal after delivery. And third trimester use has also been associated with problems with the baby being able to regulate its temperature, problems with breathing, problems, of course, with drowsiness, and this muscle weakness, which is also just a complete lack of tone, muscle tone. Muscle tone is what allows people to like sit up or hold their head up, or hold your arms up, and it leads to this floppy baby syndrome, which sounds funny, but it sure doesn't look funny. The baby can't hold his or her head up, they can't sit up, they can't move their limbs, basically. So it's just a complete lack of tone, muscle tone. I believe this is something that's temporary, and within a week or two it goes away, but I don't know the entire pathophysiology of that one. So the difference between short-acting and long-acting benzodiazepines, with intermediates being somewhere in between, is, are they inactivated directly by metabolism, or are there active metabolites? And long-acting have active metabolites, short-acting do not. So when a long-acting drug is metabolized, sometimes the intermediates, or if you start with a drug, you metabolize it, you end up with this intermediate. Sometimes that intermediate, before being metabolized finally to something that can be eliminated by the kidney, is actually more active than the original drug was. That's often the case with these long-acting benzodiazepines. And benzodiazepines, at least clinically, are grouped by how long they act. The short-acting ones are often the ones that are used for surgery, like midazolam or triazolam. Some of the intermediates can be added to a long-acting, but during the attempts to control the symptoms of alcohol withdrawal, almost universally, a long-acting benzodiazepine is the foundation of that treatment plan. Intermediates or short-acting can be added to it for symptom control, but usually this is what's used to try and reduce the chances of the person experiencing seizures or DTs. So in this relatively complicated diagram, what I did was put a blue box over the ones that are considered long-acting, and you can see this is the common pathway for almost all benzodiazepines to be eliminated. They're turned into oxazepam, they're conjugated, and they're eliminated in the urine. But most of these long-acting ones, especially this diazepoxide, has two intermediate active intermediates, and then this active intermediate that actually has a half-life of 30 to 100 hours. So that one's got a really long half-life. And this flurazepam, in and of itself, is completely inactive. It has no effect on sedation or anything like that, but it's metabolized into these two intermediates, one that has a short half-life of 2 to 4 hours, and one that has a very long half-life of 40 to 100 hours. So this is just looking at elimination half-life of benzodiazepines and some of the newer hypnotics down here. The sleep aids, zolpidem is Ambien. And some of these long-acting benzodiazepines have really long elimination half-lives. It's to give you some idea of how different it is to be in the long-acting versus ultra-short-acting groups. Orders of magnitude different. Some of the things that affect the physiologic or affect pharmacokinetics are physiologic. The big one is aging. Another one, of course, is gender. So, well, I won't get into the specifics, but basically, as you get older, the chances of overdosing using a benzodiazepine increase. And so what you used to be able to handle when you were younger is no longer something that you can handle, especially if you're adding something like alcohol. And I think that's a frequent cause of overdose for celebrities. Some other things are obesity level, liver disease, because the liver is doing most of the metabolizing, kidney disease, because the kidney is what's actually filtering the metabolites out and eliminating them, and then ethnicity, because that controls some of the liver enzyme types and how quickly they metabolize things like diazepam and alprazolam. This is more for your benefit. If you know that your client is on one of these drugs, you can look here and you can see what its onset of action is. It intermediate, rapid, or slow? The peak onset in hours, half-life, and then how is it eliminated, and what's the dose equivalent, because there is a significant difference in potency for these different drugs. Same with this. I mean, I'm not expecting you to look at this and go, yep, got it. Go ahead and quiz me. I'm not going to test you on this stuff. What I do want you to be able to do is look back and look in this table if you know that your client was abusing diazepam, and then you can know more about what happens when they took diazepam.
Gamma-aminobutyric acid, or GABA, is the primary inhibitory neurotransmitter in the mature brain. It reduces neuronal activity of target cells through its binding to GABA receptors present on the cell surface. Nearly half of all synapses of the brain express some kind of GABA receptor and are thus responsive to GABA. There are at least 3 types of GABA receptors: GABA A, GABA B, and GABA C. GABA A and GABA C are ligand-gated chloride channels. Upon transmitter binding, they open and allow chloride ions to flow into the neuron, making it more negative or hyperpolarized and thus less likely to generate action potentials. GABA B acts through a G protein to activate potassium channels, which allow positively charged potassium to flow out of the cell, again resulting in membrane hyperpolarization and a subsequent decrease in neuron responsiveness. GABA is believed to play a major role in controlling neuronal hyperactivity associated with fear, anxiety, and convulsions. GABA A receptor is composed of 5 protein subunits. In addition to binding sites for GABA, it has allosteric binding sites for other substances, known as GABA modulators. These are molecules that can increase or decrease the action of GABA, but have no effect in the absence of GABA. For example, benzodiazepines, a class of drugs used to treat anxiety, bind to GABA A receptor and facilitate its binding to GABA, thus potentiating GABA inhibitory effect. Other positive modulators include barbiturates, alcohol, and propofol, among others. Examples of negative modulators are convulsants, such as flumazenol. Flumazenol reverses the effects of benzodiazepines by competing with them at the same binding site on GABA A. Thank you for watching. Please feel free to suggest a topic you want us to cover by leaving a comment below.
In this lecture, we're going to cover the pharmacology of anxiolytic and hypnotic drugs, so let's get right into it. The primary use of anxiolytic and hypnotic drugs is to treat anxiety and insomnia. Anxiety is generally defined as an emotional state characterized by excessive feelings of worry, fear, and nervousness, while insomnia is generally defined as the inability to initiate, maintain, or achieve restful sleep. Now, in order to gain better understanding of how anxiolytic and hypnotic drugs work, first we need to discuss the role of GABA in the central nervous system. So, gamma-aminobutyric acid, or GABA for short, is a major inhibitory neurotransmitter. What that means is that when GABA reaches and binds to a specific receptor located on a neuron, it reduces the activity level of that neuron and makes it less likely to fire its action potential. Now, GABA is recognized by both ligand-gated and G-protein-linked GABA receptors. In this lecture, we are going to focus on the ligand-gated GABA receptor called GABA A, as this is the main target of many anxiolytic and hypnotic agents. Now, the GABA A receptor is made up of 5 subunit proteins arranged to form a central pore. These subunits have been labeled with Greek letters such as alpha, beta, gamma, and delta. The subunit composition of GABA A receptors in the brain most frequently consists of 2 alpha subunits, 2 beta subunits, and 1 gamma or delta subunit. Furthermore, for each subunit, many other subtypes exist. The function of each GABA A receptor depends on which subunit it contains. For example, GABA A receptors containing alpha 1 subunit appear to be involved in sleep, while those that contain alpha 2 or alpha 3 appear to be involved in anxiety. Now, when 2 GABA molecules bind to the GABA A receptor, conformational change is induced, which results in opening of the central pore that allows negatively charged chloride ions to rush into the cell. This in turn increases the negative charge inside the postsynaptic cell, which makes more difficult for an excitatory inputs to cause an action potential. Now, GABA A receptors are present in high concentration in the limbic system. One part of the limbic system is the amygdala, which contains many neurons that use the neurotransmitter GABA to control feelings of fear and anxiety. In times of stress, excitatory neurons in the amygdala fire rapidly, sending excitatory signals to other areas of the brain. It is this type of firing that leads to feeling of panic or fear. The inhibitory interneurons in the amygdala regulate these emotions by releasing GABA. The release of GABA and its binding to postsynaptic receptors such as GABA A inhibits the excitatory signals that result in feelings of anxiety and fear. GABA thus has a calming, tranquilizing effect on our emotions and prevents us from becoming overwhelmed in stressful situations. Now, in addition to a distinct binding site for the neurotransmitter GABA, the GABA A receptor has also a site at which anxiolytic and hypnotic drugs bind. These drugs can be divided into 3 groups, that is, benzodiazepines, barbiturates, and non-benzodiazepine hypnotics. Let's now discuss these one by one in detail, starting with benzodiazepines. So, benzodiazepines get their name from their chemical structure, which includes a benzene ring fused to a diazepine ring. Their binding site appears to be the region between the alpha and gamma subunit on the GABA A receptor. It's important to remember that benzodiazepines do not bind to the GABA recognition site located at the junction of the alpha and beta subunits, thereby they don't induce opening of the channel as directly as GABA. Instead, the binding of a benzodiazepine to its receptor site increases the affinity of GABA for the GABA binding site. This leads to increased frequency of the channel opening, and in turn increased influx of chloride ions at the postsynaptic cell, which ultimately makes difficult for any excitatory inputs to cause an action potential. So when the excitatory signals caused by fear or stress are inhibited in this way, the result is decreased anxiety and greater feeling of calm. In addition to that, benzodiazepines can also produce mild muscle relaxation as a result of their action on GABA receptors in the spinal cord, cerebellum, and brainstem. The examples of benzodiazepines are alprazolam, chlordiazepoxide, clonazepam, diazepam, lorazepam, and temazepam. When it comes to side effects of benzodiazepines, the most common ones are related to their sedating and muscle relaxing action. They include drowsiness, dizziness, decreased alertness and concentration, as well as impairment of motor coordination. Now let's move on to the next group, that is barbiturates. So barbiturates bind to GABA A receptor at the alpha or beta subunit, which is different from the GABA binding site and also different from the benzodiazepine binding site. Now, just like benzodiazepines, barbiturates enhance the effect of GABA at the GABA A receptor. However, instead of increasing the ion channel opening frequency, they increase the ion channel opening duration. In other words, unlike benzodiazepines, barbiturates hold the ion channel open continuously for long periods of time. In addition to that, barbiturates can decrease the activity of excitatory neurotransmitters such as acetylcholine and glutamate, and at higher doses, they can also mimic GABA and directly activate GABA receptors, thus leading to profound central nervous system depression. This is why barbiturates have a much lower therapeutic index than benzodiazepines, meaning the toxic dose is not much higher than the therapeutic dose. The examples of barbiturates include pentobarbital, phenobarbital, and secobarbital. When it comes to side effects, barbiturates most often cause dizziness, lightheadedness, sedation, as well as memory and attention impairments. Furthermore, because of their narrow therapeutic index, it's important to remember that even small barbiturate overdose can result in coma or death due to respiratory depression. Now let's move on to our last group of drugs, that is non-benzodiazepine hypnotics. As I mentioned at the beginning of this lecture, GABA A receptors in different areas of the central nervous system consist of various combinations of the subunits. The specific subunit that appears to mediate sedation is the alpha-1 isoform. So as their name suggests, non-benzodiazepine hypnotics are structurally different from the benzodiazepines, and as you may already guess, they selectively bind to the alpha-1 subunit of the GABA A receptor, thus triggering chloride channel opening with resulting membrane hyperpolarization. Because alpha-1 containing GABA A receptors are highly expressed in wake-promoting regions of the brain, the preferential binding of non-benzodiazepine hypnotics to these receptors results in sleepiness but not anti-anxiety effect. The examples of non-benzodiazepine hypnotics are zolpidem, zaleplon, and ezopiclone. When it comes to side effects, non-benzodiazepine hypnotics can cause cognitive impairments, including memory loss, daytime sedation, as well as impairment of motor function. And with that, I wanted to thank you for watching. I hope you enjoyed this video, and as always, stay tuned for more.
So when it comes to pharmacodynamics, I think to me this ink blot means the shattered self. Often it's kind of like blurring too. Your existence is blurred for a while. Anna Nicole Smith had at least 3 different benzodiazepines and chloral hydrate on board when she died, and her physician had his license revoked for overprescribing to her. Well, part of the reason I highlight what happened to these physicians is because I think it is something that's controversial. I think it's something that is different in every case. And I think that trying to legislate what a physician does with their patient is something that at best is tenuous and most of the time pure foolishness. But don't you think she could be pretty persuasive if she wanted to? The other problem is that I'm sure that physician never intended for her to take diazepam, clonazepam, and lorazepam and chloral hydrate at the same time. That's true as well. And even if she got them all from the same doctor, maybe she got 1 month some diazepam and the next month some clonazepam, and maybe the next month she's like, nah, that's not working for me. I need some lorazepam. And then she already had some chloral hydrate. And then she decided to take, all 4 bottles and take some of each one. And they were never meant to be taken together. And that's, part of what I'm getting at is it's not, I think, not as easy as looking at how did this person die and then saying, wow, damn, that doctor was stupid. because you have to kind of, get into what really happened. Like, did they really prescribe this person for depressants and say, hey, take as many as you want, as often as you want, all together if you want? No, I'm sure they never, ever said anything like that. And if you'd been Miss Smith's doctor for, I don't know, 10 years, 20 years, and her escalating use of these drugs, and you're trying to tell her, hey, this stuff could kill you, do you say Miss Smith was an addict or was she dependent? And it matters, because if she's an addict, then you're perpetuating her addiction by continuing to prescribe. If she's dependent, that's expected. And are you increasing the amount that you're giving her because of tolerance, which is part of dependence? Or are you increasing it because she just wants to get high more often, which is addiction? And how would you know? That's the problem to me anyway. It's like, how the hell? But it happens, obviously these people get their license yanked, and who knows whether it's actually because there was any kind of, malpractice, any kind of negligence, or any kind of malice. I don't think there was any of that involved. It's, how far down the garden path do you go? But anyway, so the mechanism of action is through the GABA receptor. Most of it's through the GABA A receptor, which is a chloride channel. When that channel opens, chloride floods into the cell, which leads to the cell having a more difficult time passing a signal along, which is usually a signal for distress or for muscle contraction or something else. So GABA binds to this receptor, and so does benzodiazepine. They don't bind to the same site. All that benzodiazepine does is acts to enhance the binding of GABA to the GABA receptor. So this is a 3D model of the GABA receptor. And then this is what happens when you add diazepam and GABA. You get increasingly stronger and stronger depression of that cell's ability to pass on a signal, which would be jumping up. And then this is zolpidem, or Ambien rather, and GABA, same type of effect. And then if you add zinc, that's actually a inhibitor of GABA. It doesn't allow the chloride to pass through the channel, so you end up getting less and less signal the more zinc you add. So you get curves like this for efficacy. So diazepam and zolpidem for that specific receptor have roughly the same efficacy, and zinc is an effective antagonist. So we already know that less signals leads to also less signals for anxiety, less signals to stay awake for sleepiness, and increased sedation. Just, you can't respond as quickly. And it also reduces the chances that you'll have a seizure, or if you're having a seizure, it can actually stop them. And it's not as important that you know all of these different types, but that there are different types, and that these different subtypes bind together. These different transmembrane domains, 5 of them will bind together, and that makes a GABA receptor. Depending on which of those subunits are binding together, you have different effects. This particular combination causes sedation. This one will affect anxiety, and this one will affect muscle tone. And this is looking at those various types and somewhat broader use. And of course, it's in French, but anxiety, sedation, muscle relaxation, reducing seizures, and then amnesia, which is forgetting. You can actually use benzodiazepines. If you get to a trauma victim quickly enough, give them a benzodiazepine, you can make them forget they even experienced the trauma, which would be wonderful for certain traumas, because you wouldn't end up with PTSD and stuff like that. So this is just looking at similar stuff, sedation, but the one of interest here is addiction, and the alpha-1 GABA A receptor subtype is the one that's primarily involved in addiction. And that's probably important to know. And this is just showing that these different receptor types are located in different parts of the brain, and they're also involved in different types of behavioral disorder or symptoms: memory or learning disruption, anxiety or mood disturbance, fatigue, sedation, exhaustion, depression induced by stress, eating disorders, relapse to alcohol abuse, balance and mobility disorders, and seizures and excitability disorders. So, not too surprisingly, relapse to alcohol abuse is located or co-located in the hypothalamus, which is part of the limbic system. And it's specifically the beta-6 GABA receptor subtype that's involved in relapse. And this is once again just showing the fate of GABA. Frequently it's being released from these presynaptic vesicles. So they're like little jars of GABA that are dumped into the synaptic cleft that can be either reabsorbed and put back into the jar. It can be turned into other things like glutamate, which is a different type of receptor, neurotransmitter rather. But there's also then an enzyme that can take the glutamate and turn it back into GABA. So there's some kind of balance between GABA and glutamate. And astrocytes are also involved. These are kind of like the helper cells for neurons. Neurons can be meters long, and most cells are, of course, microscopic. So something that big may rely on another cell for energy, like an astrocyte. I think most people are already familiar with the short-term side effects of benzodiazepines, but they can cause immune problems, just like opioids. They can affect cancer risk, lead to mental disorders, and aggression. Like, what the-
Taking these pills probably.
Right, but the idea, I think, with that is not that the benzodiazepine couldn't kill them all by itself, but that sometimes when you take benzodiazepines and alcohol, the effects actually, instead of adding, multiply. And so what normally would be a just fine dose for alcohol and a just fine dose for benzos put together turn into a deadly dose. Yeah, absolutely. That's why it's on most bottles. And this is a benzo with alcohol, killed Amy Winehouse. This is the location of action in the central nervous system and the effect, whether it's alleviating anxiety and fear, which are primarily in the limbic system, confusion, forgetting, and seizure activity in the spinal cord and hippocampus, and then, not too surprisingly, the muscle relaxative effect in the cerebellum, parts of the brainstem and the VTA. And then the nucleus accumbens, which is where we have that, wanting and liking portions, not surprisingly involved in abuse and dependence for these drugs as well. So this is just looking at what constricts pupils, what causes red eyes, and what causes dilated pupils. Traditionally, opioids cause constricted pupils. They're not the only thing that can, but they're the usual drug of abuse. Marijuana is, I think, traditionally associated with red eyes, but cocaine and crack can do it, and so can benzos, and so can a large amount of a depressant like alcohol or other sedative. And then the dilated pupils is usually caused by stimulants, but also hallucinogens, and some opiates can cause it. Marijuana can cause it. And of course, withdrawal from an opioid can cause enlarged pupil, and withdrawal from a stimulant can cause constricted pupils, just to keep things interesting. So benzodiazepines increase your risk of a fall if you're elderly by about, well, 1.5 times, so 50% increase. And that's unfortunate because often falls for elderly mean a broken hip. And for shorter acting drugs, benzodiazepines often can help you get to sleep, but then result in you waking up much earlier than you wanted because the drug wears off and you're no longer tired. For long acting ones, it isn't terribly helpful in getting you to sleep because it doesn't take effect very rapidly. And then it has the problem of you feeling very tired the next day. And that's why they came up with those sedative hypnotics to try and have a more rapid onset and a longer duration. And the other problem with trying to use benzos for sleep is that you get less REM sleep. So you feel less rested the next day. This is an example of a normal sleep hypnogram, which is showing the level of sleep, and the blue is REM sleep. And when you take a benzodiazepine, you don't get into the lower levels as much, and you end up with less REM sleep overall. So it gives you this kind of drugged sleep, which is not as deep and not as relaxing, not as refreshing the next day. And another, I particularly liked his work, so I hate the fact that it killed him, but he had at least 3 benzodiazepines, some opioids, and an antihistamine on board when he died. And then for motor vehicle accidents, like I was showing you before, alcohol is strongly correlated with having a car accident. For benzos, 50% means it could go either way. Might be your fault, might not. 50-50 you'd consider to be normal. For a subtherapeutic dose, it increases it to about 10% greater likelihood that it was you that caused the accident. If you're using them as prescribed, it's about a 30% increase. And if you're, of course, above that therapeutic level, they say 80% likelihood you're the one that caused the accident. I would say it pretty much goes all the way up to 100% the way people use benzos these days. And here's Michael Jackson. And of course, his physician got to spend 2 years in prison for his involvement in Jackson's death. But once again, it's one of those things where I think everything about that case was flawed. And I think it's more a reflection of the culture that we live in than specifically Jackson or his doctor. So when it comes to cognitive impairments, you get short-term impairments in learning, academic performance, being able to actually move your limbs, psychomotor functioning, and those can persist for months after you stop treatment. And that's just for 6 months or less. For long-term treatment, it can affect memory, attention, your ability to process information, solve problems, your ability to respond, and also your ability to see and know what you're seeing. So these people are not ones you'd want to have driving. And when it comes to looking at the cognitive problems, this is the cognitive impairment weighted mean effect size. So sensory processing was the thing that was most affected. The overall effect size was about 80%. 80%. Not great. Another interesting thing, in 2019, they found out that there was an additional protein that was required for benzodiazepines to actually have their reducing anxiety and sedative effect. So it's not just the fact that there's chloride jumping into the cell. There's also some role for this protein, not sure what, but if it's not there, it doesn't work. And then, of course, another death, and I could probably put a slide at the end with 50 more, but this is the difference between tolerance and addiction. Supposedly, tolerance is something that the non-addictive therapeutic benzodiazepine patient that has just dependence will go through the withdrawal syndrome if you discontinue the drug, but they won't have these problems that the addict has. And why they put tolerance on this, I don't know, because what they're trying to say is that tolerance is not something that's normally exhibited by patients in treatment. I think that's bullshit. But anyway, the one thing that is common between the two is dependence. They're both physically dependent on the drug. The other stuff, the cravings, the preoccupation with getting a dose, the uncontrollable drug-seeking behavior, the adverse health and social consequences, those are usually part of the definition of addiction. So of course they're going to be on the addiction side. But this one, I don't agree.
This tolerance is not a lesson that I can do this.
That I need more of it to get the same effect that I had,
And still be,
a couple months ago.
Get that effect and still be like not out of control. You know what I mean? Like
Right. What they're
using something they're totally different. You know what I mean?
Yeah, what they're trying to say by this, to include tolerance here, would be that you have enough space between the time when you took the prescribed dose and when you take the next dose for your body to physiologically recoup to normal. But that's not always the case. So the other problem is that benzodiazepine therapy, even though it's supposed to be just 3 months, often results in a withdrawal effect, which results in a lot of anxiety and hyperstimulation. And if the withdrawal is bad enough, it can actually lead to a seizure disorder. And I've seen patients end up with the seizures and then come to me saying, hey, I need a refill because I'm getting seizures. And then you're like, what the? I would have never prescribed you that much benzos to begin with. And they're like, I'm getting the seizures now. I need the medicine. And you're like, what's the right answer here? 911? So there's benzodiazepine withdrawal syndrome. Not too hard to identify. Another overdose death, but it's similar to alcohol and it can cause life-threatening seizures. And that occurs especially when you abruptly and rapidly either abruptly end taking it or rapidly taper. Most people, especially when they're taking something addictive, try to, go from taking a bunch of it to all of a sudden taking none because they want to be, clean. They want to enter abstinence. And so they either very rapidly taper it if they do that at all, but most abruptly end it. And that's what leads to this severe withdrawal syndrome. So these are some of the withdrawal symptoms, but having trouble sleeping occurs in almost 60% of people. So that's the one that I would say is most important. And then if you've ever seen, or I made a bunch of puzzles by Thomas Kincaid, well, made of his paintings anyway, but he also died of a combination of benzodiazepine and alcohol. And then there's Whitney Houston. And there was an article that benzos are the drug of the age because panicked strivers have replaced sullen slackers as the caricature of the moment, and Xanax has eclipsed Prozac as the emblem of the national mood. Jon Stewart has praised the smooth, calm, pristine, mellow, and sleepy feeling of Xanax. Bill Maher has wondered whether the president himself is a user, and he's eloquent and unflapped. He's so cool and calm, like U2 or Lil Wayne, who wrote songs about Xanax. And then, of course, there's, this book, Dirty Sexy Politics, where McCain's daughter admitted to dosing herself and passing out on the day of the election, still in her clothes and makeup. When news outlets began reporting that the cocktail of alcohol, Valium, and Xanax might have caused Whitney Houston's death, it felt oddly inevitable. The Coke binge are a frenziers era, and now people who overdid it are trying to calm down, said Lisa Miller in this Listening to Xanax from the New York Magazine. So there is an antagonist, just like there's Narcan for opioids or naltrexone, and that's flumazenil, and it actually binds to the GABA receptor and won't allow it to be activated. So it blocks benzodiazepine's activity. Problem is, of course, it's rapidly metabolized by the liver, has a very short half-life, and administering it to overdose victims, unfortunately, is controversial at best, given that it often induces seizures in people who've been using benzodiazepines at high doses for a long period. So it's better, I guess, what they're trying to say is that you treat them with naloxone in case it's an opiate overdose, and then give them CPR until you can get them on a ventilator and let the benzos just wear off. Because as long as you can treat the respiratory depression with a ventilator, that's better than inducing seizures by giving them the flumazenil, which is really unfortunate because if you could just give them the flumazenil without that kind of complication, it would be as easy as giving somebody Narcan. No problem. And then Philip Seymour Hoffman, 2 benzos and heroin. So you've got benzodiazepine receptor ligands are either agonists, which stimulate the receptor, or antagonists, and then you have inverse agonists, which can actually cause people to be stressed or anxious or have seizures. And there's relative safety. You can see that morphine is not very safe in terms of its therapeutic index. Or promazine was only a little bit safer than morphine. Phenobarbital on the order of what, 60? No, 50. And then diazepam, though, has a therapeutic index of about 1,000. So all by itself, anyway, much less likely to cause an overdose. And so that's what accounts for, at least in part, the difference is benzodiazepines increase the frequency with which the GABA receptor opens. Barbiturates increase the duration that the receptor opens. So at high doses, GABA receptors open, thus blocking respiration altogether when the receptor is just held open. And that's what led barbiturates to be much more deadly. And alcohol has the same effect as a barbiturate and just requires a much higher dose. So alcohol holds the receptor open for a longer period of time. And that's why you can die of alcohol poisoning. Benzodiazepines all by themselves don't cause that effect. So just increasing the frequency, if the GABA is not around, won't actually keep the receptor open independent of the GABA. But barbiturates and alcohol both can hold the receptor open all by themselves and don't need the GABA to be there, thus deadly. And this is central nervous system anesthesia versus dose as you increase the dose. So benzodiazepines kind of have the effect like Subutex or Suboxone, the buprenorphine, where it has an efficacy rather that is limited, doesn't actually cause medullary depression and coma and death like barbiturates as you increase the dose continues. And also this is just showing that with tolerance for barbiturates, you don't get tolerance for the toxic effects. It doesn't increase at the same amount. So you're actually decreasing the therapeutic index as you're increasing tolerance to a barbiturate, which is kind of unique to barbiturates and probably is what led to so many deaths in the 60s. Well, this is as you increase how long you've been using a barbiturate, your tolerance to the actual therapeutic effect, like the sleep, the reduction in anxiety, increases at a much greater rate than your tolerance to the toxic effects. So over here, this is the therapeutic index when you start, which say that's 100. So you've got some room between, if you take this dose you'll get the effect, but you'd have to take several times that dose to get any toxicity. But by the time you've used it for a year, you're over here and you have to take this dose to get the effect, and you only have to take a little bit more to die. And George Michael, damn it. Benzodiazepines, GHB, alcohol, marijuana, methadone, and antidepressants. Man, he just took the whole lot. And it was ruled natural causes, which I think is more because he wanted to keep it private, I guess. But usually the reason that people die is not the benzodiazepines alone. It's a combination of CNS depressants like alcohol, opioids, antihistamines, barbiturates, and then non-sedative barbiturate or non-barbiturate, non-benzodiazepine sedatives. That's a mouthful. So there are three complementary ways to suppress breathing. One is by lowering the GABA inhibition. One is by slowing the respiratory rhythm in the midbrain. And one is by decreasing your response to CO2. So that's why they're multiplicative instead of additive, because they're affecting different mechanisms. So your response to CO2 times your response to the respiratory rhythm multiplied times your GABA inhibition is what keeps you breathing. And anytime you sedate or depress one of those, that has an effect. But you suppress two, and it's instead of 1 + 1, it's more like 3 × 3 is 9 instead of 3 + 3 is 6. Yeah, so benzos plus opioids increase the likelihood of fatality by 200 to 400%. And people use them in combination because they say there's a synergistic euphoria. And of course, the FDA warns against using them together. Well, that's good of them. And then, damn it, Prince. Of course, everybody knows, or I think everybody knows, that he was using fentanyl, but he also had a benzodiazepine along with clonidine and this hydroxyzine again, which is an antihistamine, which is another depressant, on board when he died. So in 2016, they finally put a warning out saying don't take benzodiazepines and opioids together because they can cause respiratory depression, coma, and death. And this is looking at the rates of use of benzodiazepines, opioids, and alcohol down here, benzodiazepines alone up here. So unfortunately, the combination of all three of these, 70%. And this is for ER visits. So if you use all three and you're over 65, you're very likely to end up in an emergency room. And this is that drug abuse warning network, ER visits. And the number of people using them all alone going to the emergency room was much greater, but that's because the number of people using benzodiazepines alone was much greater. But actually, as a proportion of the people using benzodiazepines and opiates, or opioids, or alcohol, or all three, it was much greater likelihood that if you're using them, you're going to end up in the emergency room. And another one, Tom Petty, I mean, of all people, jerk, have to go and leave us like that. 2 benzos, fentanyl, oxycodone, and an antidepressant. And for Americans in 2015, 1 in 3 are prescribed an opioid, 1 in 12 a benzo, and 1 in 30 are prescribed both. And 40% of opioids for chronic pain, or people that are taking opioids for chronic pain, are also taking a benzodiazepine. And accidental drug overdose now it's from 25 to 55 or 65 even, is the leading cause. And it's not the leading cause of injury-related death, it's the leading cause of death, period. So I don't know if we really have to get into all that. This is just looking at overdose deaths from benzodiazepines, and then looking at what else they had. So in green is benzos and any opioid. The light green down here is benzos all by themselves, and then benzodiazepines with most likely fentanyl here in the orange. And I didn't really follow this musician, but she died from a benzo and a very high blood alcohol level, along with nicotine. So this is a comparison chart. It just looks at a bunch of the characteristics like some of those other ones to try and help you put the whole thing together if you want to. There are, of course, anxiety relief alternatives. And so because we're supposed to be full of alternatives for people that use these drugs, cognitive behavioral therapy is one of those that's recommended. The one I would recommend is mindfulness, specifically mindfulness meditation or breathing exercises for people who can't hold still. Yoga or Tai Chi are great alternatives to meditation. And given that, I think it was a story in the New York Times yesterday, was talking about how a group of physicians, I think it was psychiatry related, but anyway, they were saying that levels of anxiety are high enough that every patient should be screened for anxiety on any visit. That recommending meditation, breathing exercises, yoga, or Tai Chi to every patient is most likely going to be useful, because right now, causes of anxiety are high enough. We've managed to whip up the storm good enough that everybody's anxious, practically more than 50%. But another one that's relatively simple, the problem with aerobic exercise is we've been drumming on that now for the last 60 years, roughly, saying, you know, what wonderful health benefits aerobic exercise has, not just for anxiety, but for almost anything. And yet we've become an increasingly more sedative society, where we spend more time sitting, maybe not watching TV now, we're on our tablet, phone, whatever, computer, and we're not exercising for sure. Another one that one of the people I work with recommends is called forest walking. It's a Japanese thing, but I think it's just hiking, you know, but you don't have to do it with hiking boots on with a plan to go for the whole day. You can just take 5 minutes and walk through an area with lots of plants or a pretty garden and try to be present where you're at, instead of worrying about all of those things, you know, and whether the laundry was done, and if you returned that phone call, and which emails you're going to have to respond to, and, you know, what your drive home is going to be like, or whether you're going to make it to class on time. All right, so then the final thing was, you know, through this whole thing, I've been showing you people that are celebrities and musicians that are dying, and often dying of benzodiazepine or barbiturate related causes. But the interesting thing also is that this is life expectancy at age 40 versus your household income. So as you increase, especially down here at the very lowest, they die a lot more rapidly than people up here. But there's kind of a trend, almost a straight line, with income for men and for women. But dying to be famous, retrospective cohort study rather of rock and pop stars mortality is associated with ACEs. And here's celebrity survival. This is how many years they've been famous, and this is looking at survival for regular population in North America and Europe in the open. So I like to say, you know, that we pay a lot more for our healthcare, but we get a lot less health for our healthcare. And this shows it, that the Europeans are paying less and they're living longer. And our pop stars are dying more rapidly as well. And that's in the solid boxes here. So your chances of death are considerably greater than average if you're a pop star. By the time you've been famous for like 20 years, it's almost 5% difference. And so to me that, well, it's related to the disease more. Absolutely. But it's also because I think with celebrity or with being a pop star comes an awful lot of pressure to be something you're not. And with that pressure comes this perception that you're being judged by everybody around you if you're not performing to that level, you know, and your latest song isn't a hit, basically. And so that leads to people seeking some type of relief, and often that's in the form of alcohol, benzodiazepines, or barbiturates. And there was another article on, you know, the stairway to hell, as they called it, life and death in the pop music industry. And this is the normal population. And this is looking at from the 50s to the 2010s. And these are pop musicians, either female in pink, male in blue, and the difference in average life, average age at death between the normal population and pop musicians. And I would say that's pretty significant, to be dying at 60 or at 57 versus what, 76 roughly. So that literally is dying to be famous. Then the latest thing is xylazine. Don't know if any of you have heard of it, but the news is calling it tranq. Unfortunately, it's a new sedative, at least new to the street drug scene. And xylazine is a veterinary medication not approved for use in humans and has the unfortunate side effect of often causing some serious problems. So it's a veterinary tranquilizer, and it's been linked to an increasing number of overdose deaths nationwide. Between 2015 and 2020, looking in Pennsylvania, which is one of the few places that actually tests for xylazine, the number of people that overdosed from an opioid with xylazine in their system went from 2% to 26%. And recently in Maryland, it was about 20% of overdoses, and in Connecticut, about 10%. The reason that people are assuming anyway, that people are using this xylazine along with fentanyl is because xylazine is harder for the DEA to detect right now, and it's inexpensive to produce. And supposedly, the reason that users want it or use it is because it increased the length of the euphoric effect of fentanyl. So instead of being such a short high, xylazine can help to lengthen that high. And I imagine that's why Xanax and Soma are so widely abused as well. But the problem is that the opioid reversing medication, naloxone, doesn't have any effect on xylazine. So if you have a high dose of xylazine on board and fentanyl, and you're not breathing, giving the overdose victim naloxone may not actually bring them back. Just another wrinkle in the overdose epidemic. It's always changing a little bit, and it's always remaining the same. And the New York Times had a story about xylazine or tranq, where they were showing some of the effects of having used tranq. It's kind of like that crocodile. It causes the death of flesh if you're skin popping, and can leave you with a lot. Well, like this poor lady has a bunch of dead fingertips, and she's most likely going to need some amputations. And this girl was using it and has scars all up and down her arms from death or necrosis of the tissue around where she was skin popping. So another not fit for man nor beast drug that's being used by people with addiction problems.